how your body compensates for that continued stimulus of a neuroinhibitory transmitter, which is GABA, is that you compensate by excreting more glutamate via your NMDA receptor. Glutamate is a neuroexcitatory neurotransmitter, which leads to more hyperactive symptoms and those alcohol withdrawal symptoms. Hello there, farmers and friends. Mark with FarmWise. I'm a board certified emergency medicine pharmacist that makes clinical pharmacotherapy content on the social medias. I often get questions in the comments and compile them into a video series called the Drug Career Inbox. I post daily infographics, reels, and patient cases on the social medias. Follow @FarmWise on your favorite platform. For this episode, we're going to do something a little bit special since we had a request from viewers on Instagram to do a full week of medigram patient cases. So for this episode, we'll talk about those patient cases and an explanation of the answers. After the review, we'll address some of the questions that were dropped in the comment section, specifically acyclovir prophylaxis in the setting of Bell's palsy, a commentary on the use of Lokelma in the acute setting, and lastly, we'll close it out with my thoughts on Xofluza or baloxavir marboxil. For the medigram patient cases, the topics we'll go over will include shockable cardiac arrest, alcohol withdrawal, urosepsis, anaphylaxis, and acute heart failure exacerbations. With that, let's get into the first medigram patient case, which, by the way, are posted on the social medias. Instagram, LinkedIn, Facebook, whatever social media platform you use, you can follow me @FarmWise. Alrighty guys, for the first patient case, we have an 82-year-old female coming in with ventricular fibrillation. CPR has been initiated and she's been attached to the monitor and pads, which confirms ventricular fibrillation. What intervention should be done next? Your options are epinephrine, amiodarone, lidocaine, or defibrillation. When we're talking about shockable rhythms, we're discussing pulseless ventricular tachycardia or ventricular fibrillation. These are found on the left side of your ACLS algorithm. They're called shockable rhythms because when we see them on the monitor during a pulse check, that means we need to defibrillate the patient. Earlier defibrillation in the setting of shockable rhythms is associated with improved survivability and neurologic outcomes. Compared to non-shockable rhythms, pulseless ventricular tachycardia and ventricular fibrillation are more associated with acute coronary syndromes, and they're more associated with improved survivability compared to non-shockable rhythms. It's important to note that, yes, oftentimes, especially for me as a pharmacist, we always think about giving medications. But you have to think about what is the purpose of those medications and the why behind it. What's the clinical benefit? When we're dealing with shockable rhythms, defibrillation and CPR are the only things that have shown to improve survivability and neurologic outcomes. Everything else will improve return of spontaneous circulation, but really, is that a real benefit for all of our patients? You have to think about what the clinical benefit is towards the patient in front of you. So for this case, our answer should be D, defibrillation. For patient case number 2, we have a 34-year-old male coming in with altered mental status, tachycardia, and diaphoresis. Diagnosis is severe alcohol withdrawal in the setting of a severe lorazepam shortage. Which medication should be given? Your options are phenobarbital, midazolam, dexmedetomidine, or chlordiazepoxide. Something that I've been doing recently is including MedShed infographics that are relatable to the patient cases. So for this patient case, our options were phenobarbital, midazolam, dexmedetomidine, or chlordiazepoxide. The big thing to note here is that patients with a history of alcohol abuse have a severe downregulation of their GABA receptor. You have to remember that alcohol is a GABAergic agent, so over time, how your body compensates for that continued stimulus of a neuroinhibitory transmitter, which is GABA, is that you compensate by excreting more glutamate via your NMDA receptor. Glutamate is a neuroexcitatory neurotransmitter, which leads to more hyperactive symptoms and those alcohol withdrawal symptoms specifically. Now, getting to those answers, midazolam would treat alcohol withdrawal symptoms since it is a GABAergic agent and a benzodiazepine, but with its short half-life and patients with a history of alcohol abuse, their downregulation of GABA receptors and midazolam's short half-life, you're going to need a ton of benzos and repeat dosing with midazolam especially. So probably not going to be the best option for these patients when you have other agents we'll discuss shortly. Dexmedetomidine is a centrally acting alpha 2 agonist, which, yes, would treat the alcohol withdrawal symptoms, the more hyperactive tachycardia, hypertension, diaphoresis, more calming the patient, but you're masking the fact that you're lacking GABAergic agonism. And so over time, what you'll do is you'll have the patient chill out, but then that's brewing up for a big upcoming seizure for the patient, and that's going to be really bad. Chlorodiazepoxide is another benzodiazepine that could be used for alcohol withdrawal, but that's more for chronic management or for more mild cases where patients can tolerate orals. This patient coming in with ultramental status, probably not a good idea to force a capsule down their throat. Our best option here with the options available is going to be phenobarbital. It acts on the GABA receptor, so it will address our concerns for seizure activity compared to dexmedetomidine. It acts on the GABA receptor, and different than benzodiazepines, it prolongs the opening time of the chloride channel. Another property that phenobarbital has that makes it a great twofer, especially for alcohol withdrawal, is that it reduces glutamate excretion, specifically by acting as a NMDA receptor antagonist. So for this patient, the best option is going to be phenobarbital. The next patient case, we have a 68-year-old female coming in with flank pain and fevers. She receives a 30 milliliter per kilo lactated ringer bolus, and antibiotics have been given. Her MAP remains 60. Which vasopressor should be given for septic shock? Our options are epinephrine, vasopressin, norepinephrine, or dobutamine. For anyone treating sepsis and infections, you should definitely be familiar with the Surviving Sepsis Campaign clinical guidelines, which were recently updated in 2021. The big thing I wanted to know in the initial patient case was that the patient received the 30 milliliter per kilo fluid challenge. That is really important because you don't want to start vasopressors early and mask the fact that you have under-resuscitated the patient. Yes, the patient might have a source of infection and might have positive Sears criteria, but the difference between hypovolemic shock and distributive shock, it's hard to differentiate between the two if you haven't completed the fluid challenge. So make sure that the patient has received the appropriate fluids, which is 30 milliliters per kilo, before continuing on to vasopressors. The big thing to know as well is being mindful of certain patient populations, but for the most part, excluding patients with a history of heart failure that are symptomatic or are in need of dialysis. Those patients, you can probably be more conservative with the fluids, but you don't want to under-resuscitate a patient and really the whole time they were in hypovolemic shock and just need a little bit more volume. So big thing to note there is make sure you give the fluids before pressors. Epinephrine and norepinephrine have been compared in the setting of septic shock. There's no difference in survivability, but there is a higher incidence of tachyarrhythmias with epinephrine, which you can attribute to more beta agonism, specifically beta 1 agonism. Vasopressin isn't necessarily considered a first-line agent for forms of shock, and it's more considered as an adjunctive therapy. Specifically in septic shock, when combined with norepinephrine, it has shown to have faster resolution of shock. Dobutamine is more considered for cardiogenic shock as it has potent beta agonism. Not only does it have beta 1 agonism, but you have to remember that it has beta 2 agonism. And since it potently binds to the receptor, beta 2 agonism contributes to vasodilation and results in hypotension. The best answer or best vasopressor for this patient is going to be norepinephrine. It has potent alpha agonism and increases systemic vascular resistance and a touch of beta 1 agonism for some help with inotropy. This one's coming in hot. You got a 55-year-old male presenting with throat swelling and hives, concerns for angioedema from peanut exposure. Which medication should be prioritized? Your options are epinephrine, diphenhydramine, famotidine, or methylprednisolone. When someone's coming in with throat swelling and hives, we should have a strong suspicion for angioedema. That's a life-threatening complication that needs to be addressed like right now. The only medication we should prioritize in this kind of situation would be epinephrine. Everything else is more for symptomatic management and can be given afterwards. With epinephrine, it provides beta 1 and beta 2 agonism, which helps with inotropy and bronchodilation. Not only that, it improves hypotension by acting upon alpha receptors and increasing systemic vascular resistance. Diphenhydramine is an H1 blocker which will treat urticaria and hives. Famotidine is an H2 blocker which will treat GI symptoms since our H2 receptors are primarily located there. And methylprednisolone is a corticosteroid that reduces inflammation. Now, there was some thought in the past that corticosteroids reduce the incidence of biphasic reactions, which is a reoccurrence of anaphylactic symptoms. Evidence thus far has shown that that is not the case, and the only thing that does reduce the incidence of biphasic reactions is earlier administration of epinephrine. So patients with signs and symptoms of angioedema and anaphylactic shock, the medication you should prioritize is going to be epinephrine. For the last patient case, we have a 62-year-old male coming in with shortness of breath. He has a history of congestive heart failure, and the chest x-ray is positive for pulmonary edema. He's been compliant with his home furosemide 40 milligrams daily. Which dose of furosemide IV should we give for an acute heart failure exacerbation? Your options are furosemide 20 milligrams, furosemide 40 milligrams, furosemide 80 milligrams, or furosemide 120 milligrams. When you're dealing with loop diuretics, it's important that you're familiar with the conversions. 40 milligrams of furosemide oral is equivalent to 20 milligrams of IV furosemide. That's also equivalent to torsemide 20 milligrams orally. There is no IV form of torsemide. This is also equivalent to bumetanide, which is 1 milligram, and that's also going to be your IV dose as well. Patients coming in with an acute heart failure exacerbation oftentimes need twice their home dose. So for a textbook answer, it would be furosemide 40 milligrams IV in this situation. Though clinically, doses greater than twice the home dose is often needed, but it has shown to be safe to go and use high doses. So anywhere between 40 to 80 milligrams clinically would be appropriate for this kind of patient case. That's a wrap for our medigram patient case review. Before we get into our Q&A, I just wanted to give my page a shout out. I really appreciate you hit the subscribe and notification bell. If you wanted to follow me on the social medias, you can find my accounts at links.farmwise.com. You can also support me by visiting my website at farmwise.com/shop and get yourself one of these cool lorazepam t-shirts. You can also get a ton of other cool pharmacy and medical related merchandise, including ketamine and propofol hoodies and t-shirts. So once again, visit farmwise.com/shop for more Farmwise cool gear. The first question comes from Ange K. Sains on Instagram, and it reads, can daily acyclovir or other med help suppress or prevent reoccurrence? And this was in regards to my Bell's palsy MedShed infograph. Acyclovir would not be indicated for suppression or prophylaxis in the setting of Bell's palsy since it's unclear the true incidence of herpes simplex causing Bell's palsy. It's only indicated in conjunction with corticosteroids and not as monotherapy for this reason. It's also unnecessary exposure to acyclovir, which does come with its own risk, including neurotoxicities and nephrotoxicity. The next question comes from Usmanli on Instagram, and it reads, what commentary would you give on Lokelma in the acute setting? Lokelma, or sodium zirconium cyclosilicate, is a potassium binder, so it helps reduce elevated levels of potassium. It's similar to medications such as K-Xylate and Valtessa, but different to those medications, it's more specific to potassium, so not associated with electrolyte abnormalities such as hypomagnesemia, hypocalcemia, or hypernatremia that you can see with the other two potassium binders. Lokelma also has a faster onset of a reported 1 hour, but when it comes to the evidence and evaluating the use in the acute setting, it doesn't really support the use routinely to be given before other proven modalities such as calcium and insulin dextrose. You have to remember that only about 10% of potassium is excreted via the feces, so you're not really getting much bang for your buck when you're trying to force down a medication that needs to be taken orally. The last question comes from The Real Nurse Diddy on Instagram, and it reads, thoughts on baloxavir marboxil. If you're not familiar with this medication, it goes by the brand name Xofluza. It inhibits endonuclease activity and prevents replication of influenza. The big selling point about this medication is that it's a single-dose therapy for treating seasonal flu. It's important to note though, the only thing this medication does is it shortens the duration of the symptoms. similar to what we have already in the readily available oseltamivir, which goes by the brand name Tamiflu. Xofluza also comes with a price tag that's about 5 times greater than oseltamivir. If the only thing I'm getting is a duration that's shortened but similar to what I have already in oseltamivir, I'd probably just tough out the Manflu and save some dollars. Thanks for staying to the end of this episode of the Drug Query Inbox. I'd really appreciate if you hit the subscribe and notification bell to let the YouTube algorithm know that I make good clinical pharmacotherapy content. Let me know what you thought of this episode or what questions you have in the comments below, and I hope you learned something new.